And we've made a couple of where we've tried to evolve the program a little bit over the past year, and have just in the past couple months gotten approval from our executive committee to refine some of the learning objectives and class requirements for students. And I think it is a really great opportunity that is pretty unique in its approach to training clinical investigators. And I want to just give a little overview, not that you all may be candidates for this, but you are almost certainly mentoring individuals who this program might be a really great fit for. You may see them as resident or fellow applicants or as junior faculty. And so one of the questions that we, in sort of, looking at our program that we've tried to focus on is what are the knowledge and skills that are needed to translate basic science findings to impact individuals and populations. And we've really tried to utilize, the work of others to help refine some of these questions and to refine our curriculum. A couple of years back, a group had gotten together to sort of look at characteristics of a translational scientist. And you can read some of these things here. And our goal is that when people finish the graduate program in clinical investigation, whether they've completed a certificate, a master's degree, or a PhD, that they will be better at these characteristics than they were when they entered the program, and that the more time and the more training they put into the program, the better they become at these various characteristics. We've also, tried to build our curriculum on the CTSA educational competencies or competency domains for the clinical research professional. Not every one of these is necessarily applicable to every clinical research professional, but these are certainly, sort of competencies that we think are really vitally important. And as we've looked at our curriculum and tried to evolve our curriculum, we've tried to keep these competencies in mind in selecting courses and requirements and options for students to go through. So you may be asking, well, graduate school, what are these, who's attending this? Who are the students in these programs? The majority of our students have completed terminal health-related degrees, whether that be an MD, a PA, a pharmacy degree, physical therapists, social workers. These are faculty. They can be residents or fellows. We have a couple of students who work in pharma and are being supported to go back and grow their skills and expertise. The majority of our students, although not all, the majority are part-time graduate students, i.e. they have full-time jobs that pay their bills, and that they see patients in clinic, or they work in the pharmaceutical industry. Although we do have some students who are MD, PhD students, and we have a few who are sort of more quote unquote traditional PhD students who had completed a undergraduate degree and are sort of pursuing a very clinically related project in working with an investigator here on campus. This program really is designed for people to sort of dip their toe in the water, if you will, and move along. So we have a certificate of Foundations in Clinical Research certificate program, which requires 4 classes: Intro to Clinical Trials 1, Biostatistics, Epidemiology, and then sort of an option of a second clinical trials or population health or informatics focus based on the interest of that individual student. Students can enroll in a certificate and decide that they want to continue on towards a master's degree, which adds some additional courses as shown here, including a ethical conduct of research course and a more advanced clinical translational science, statistics, or methods course, in addition to a couple of other sort of fundamental skills courses. And students who complete a master's can also go on to complete a PhD, really building on the work that they did in their master's and or certificate, but adding more depth to the process. So grant writing, additional clinical translational science, statistics, or methodology course, in addition to adding a little bit more breadth over what a master's student might do. And I think it's also worth noting for those of you who may mentor graduate students in a number of other graduate training programs that students can complete a PhD minor in clinical investigation that requires just 3 courses, clinical trials, sort of an elective course, and then a advanced statistics or methods course that hopefully fits really nicely to their ongoing PhD work. And so can do this without a great deal of extra classwork. With that, I'm happy to take some questions. I'll paste this information into the chat. Jenny Schroeder and Deirdre Vinovincius are sort of student managers who can answer questions. They help students through the application process. And I serve as the faculty director. I'm always happy to answer questions as well. If we have a couple of minutes, I'm happy to take questions now, or people can certainly reach out by email if they have somebody who might be interested in pursuing this. The very last thing I'll say is that we have tried to get this curriculum into a setting where a motivated student could potentially complete a master's program in a 1-year, pretty intense, but a 1-year period. If they were a resident and had a research year, it would be possible for them to complete a master's program during that research year. So with that, I'll stop. Thanks a lot for your time.
Thanks very much, Randy. If there are any questions for Dr. Kimple, please post them in the chat. In the meantime, it is my distinct pleasure to introduce Dr. Olayinka Shiyanbola, who is an associate professor in the Division of Social and Administrative Sciences at the University of Wisconsin School of Pharmacy. And she's an associate director at the University of Wisconsin Collaborative Center for Health Equity. Her work has focused on the use of patient-centered interdisciplinary approaches to improve diabetes and related chronic disease outcomes in marginalized populations, medication use, health literacy, and health equity. Currently, her research is focused on implementing behavioral interventions that engage peer mentors to address psychosocial and sociocultural factors affecting medication adherence, diabetes self-management, and health literacy. As an NIH scholar and fellow, Dr. Shiyanbola received training in health disparities research, randomized behavioral clinical trials, and mixed methods. She was a Society of Behavioral Medicine Leadership Fellow and is an appointed member of the National Academies of Science, Engineering, and Medicine Roundtable on Health Literacy. Her work has received numerous awards and recognitions. She's the author of over 70 publications, about 160 scientific presentations, and what a delight it will be to welcome her as the speaker for our clinical trials symposium today. Thank you so much, Dr. Shiyanbola, and I will pass it over to you.
Thank you so much, Dr. Sapta. Thank you for that very welcome introduction that you gave. And I appreciate again the opportunity to be here today. So I'm going to jump right in so that I can make sure that I get through all my slides. A couple of things I wanted to mention as a disclaimer before we get into the content is when we talk about health literacy and community engagement, the disclaimer is that no one is perfect. No one is figured out all the details and the perfection around incorporating community engagement into health literacy. I think it's okay to make mistakes. The most important thing, of course, is being attentive so that you are not making the same mistakes and repeating the mistakes all over again. And so I wanted to put that disclaimer at the very beginning, because even I continue to learn all the time from the community I work with. So starting off community-based clinical trials, I know there are a lot of people in the room or in this virtual space that think about clinical trials that are done in academic medical centers. But what I want to talk a little bit about today, which are the concepts around community-based clinical trials, are also applicable to these academic medical centers, and even if it's industry-based clinical trials. So one of the things I would say about community-based clinical trials is these are trials that are done in the community setting. things that are a little bit different from academic medical centers could be also done through a primary care physician, a community health center, an urgent care clinic, done through a pharmacy. And community-based clinical trials are important because we know from literature that at least 70% of patients don't live close to these academic medical centers and can participate in clinical trials. And this is the reason why other trusted sites become very important to consider when you are thinking about those barriers, that lack of outreach to marginalized communities, and that might not allow them to participate in a clinical trial that is based in an academic medical center. Other things to think about as well as we think about diversifying our clinical trial participants is that many of these individuals in these communities come from underrepresented groups. And for several reasons, whether it's lack of trust with academic centers, don't want to participate in clinical trials. And there is actually a specific quote that I put in here where patients who live in rural or medically underserved areas, they are actually looking to individuals and trusted individuals in their community, that long-term local physicians that they talk to about their health, they talk to about their therapy options. They are looking to those individuals to give them information about clinical trials. And so those local settings where we are not able to get to reach our communities, we have all those local trusted messengers, those local physicians, those local pharmacists that can help us reach those populations. So I sort of divided my presentation today into a couple of things to think about pre-clinical trial, during clinical trial, and now get to post-clinical trial because there are a couple of things to still think about even after the clinical trial is over. The first one, of course, is doing active listening. This is where we are directly engaging with the community. We are trying to understand what the need of the community is. And when I say community, it's not necessarily, it could be a special interest around a group of people, maybe a group of people that has a specific disease. It might be a group of people maybe who are incarcerated. And that is the community that I'm talking about. And a lot of time, there's a lot of misalignment between what we are as the PI or even the sponsor has thought about in terms of the plans for actually conducting the clinical trial. And this is why early at the very beginning, before the trial even starts, before we even write the grants to do the clinical trial, we have to take time to listen and to engage directly with them to understand if our priorities even align with the priorities of the community. It's also important to think about working and partnering with trusted messengers in the community. These are credible members in the community. It could be a faith-based leader. It could be a business leader, even a community organizer that is part of a nonprofit organization. Are the individuals that people want to listen to when it comes to clinical trial. And so it's important to think about how do we at the very beginning work together and bring these individuals at the table prior to even writing the grant, prior to even getting started with the clinical trial. There are lots of studies that have also shown us that there is low awareness, especially in historically marginalized communities, about not just clinical trials, but an understanding of what the process is all about. And so a lot of people, if we don't understand the process, why would they want to participate in a clinical trial? And so making sure that there's culturally appropriate education and even using trusted messengers to help leverage that education and information to the community becomes important. The message also has to be culturally relevant. The approach has to be culturally relevant as well when we are communicating, whether interpersonally with the community or whether we are using a type of media platform. One of the things I think about is it could be the right message, but be the wrong messenger. And at the same time, it could be the right messenger, but the wrong message. And so it's important to think about, is it a culturally appropriate message that we are communicating? And is it the right messenger at the same time? So I wanted to share these slides because I think it's very revealing of how potential participants actually get to know about clinical trial. And they did this study through the patients program at the University of Maryland Pharmacy School. And they talked to a bunch of people. And as you can see on the very left side of my screen, there's a ton of ways that potential participants get exposed to clinical trials. There's the media, there's the social media, talking to a family member, talking to a primary care physician. What I think is interesting is where you see the dotted sort of in the bar graphs, and you will see there is a comparison between the individuals in the gray line who are the white versus other racial ethnic groups. And you see that most of them get exposed. Individuals in racial ethnic groups get exposed mostly through social media platforms compared to whites, and also from community members, so the blue line, compared to white populations. And that becomes interesting because it's important to know that how exactly are the participants in my studies actually finding out about clinical trials? And this study reveals that for marginalized communities, community members, those trusted messengers that I mentioned, and also social media are the ways that they're getting exposed. And then if you look at the right end of my screen, they also see what is the preferred audience that you want to discuss clinical trial. Now, thankfully, we see that many of them at the very end is primary care physicians. So we see that many of them want to talk to their primary care, they want to talk to their family members. And so we see that variation going down. But if you see, again, at this bar where you have sort of this this shaded or line, you see the community members. You see a little bit of a flip between individuals from marginalized communities and other populations, where they prefer to discuss clinical trials with community members in the blue compared to white populations. And this again highlights why community members, individuals in the community, those key informants in the community, those trusted messengers become important to collaborate and partner with. Now, I think it's important when we do a clinical trial or do a research to think about how do we complete a research study as a way to also stir action and empower the community as part of the process of a clinical trial? And there are several ways to do this, and I'll talk a little bit about that and share some of the examples we've done. Of course, it's important to think about the resources that you're providing to these trusted clinical trial sites. Like I said, the clinical trial sites could be a church, it could be a community center, it could be a primary care clinic. But thinking about providing financial support for them, because they are the ones that can help you disseminate that information about your clinical trial information and also help you break down those barriers because they are a trusted site. But we need to make an investment financially for them to be able to do that job. Another way to empower them is also to think about how do we sustain the training of their staff beyond the life of the project. And it's important to at least start the conversation early. We might not have at the very beginning very concrete steps on how we are going to sustain the project or sustain the trial and sustain the innovation beyond the clinical trial, but it's important to start early and start thinking about what are some ways we can start thinking about sustainability now at the very beginning. Do we need to train your staff? Do we need to write grants? Do we need to buy you technology? Do we need to help you provide infrastructure? Another thing I'll talk about is another way to empower the community is a facet of health literacy, which is research literacy. Now, health literacy is this ability to be able to read, to be able to understand health information. But a very key component of health literacy is actually that ability to be able to empower the participant to take action on the clinical trial or health information that you're providing to them. And if they do not have enough education on the details of the study or even the process, then we are actually not empowering them to be able to participate in the trial and participate in our research study. And that is a way to combine research together with action for the community. So I wanted to show this article. It's an article that we've based a lot of some of the trial processes that we've done that was published by Dr. Schaufman in 2021. And these authors used an approach called the motivation interviewing approach. And it is a very proven method to actually enhance retention and enhance attendance for clinical trial participants. As you can see at the left of my screen, it talks about this methods motivational interviewing approach where you actually bring in potential participants before randomization, before they've completed the informed consent form. And you do what is called the prerequisite orientation, where you actually walk them through what is the rationale for even being part of a clinical trial, using very plain, accessible language as a way to enhance health literacy and research literacy. And then you do a motivational interviewing to diffuse any ambivalence they might have about participating in a clinical trial. You explain all the principles around randomization, why retention is important. And the nice thing about this MMI approach is that it is readily adaptable. You can do it in person, you can do it through webinars. We in our projects have actually done them using an in-person approach. So I'm going to show you what this prerequisite orientation looks like. This is an example of a clinical trial that we're currently doing. We call it session 0. We screen the participants, we tell them that they have to participate, and it is a prerequisite to even be part of the study. And we tell them this is an orientation about the process of the clinical trial that we're going to tell you about. Like I said, randomization hasn't happened, informed consent hasn't happened. We want to empower them to make an informed decision about whether they even want to participate or not. And so it is our session 0. And this is actually an exact slide from that session. This is another exact slide that we use where I as the PI actually walk them through what is a clinical trial. So I have another slide, I tell them what is a clinical trial, what is research, and then I show them what is randomization and why do we even do randomization. And as you can see, a very important health literacy principle is using pictures, using lay language, and I take time to explain that we are placing study participants in different groups. It is done by a computer program. And the reason why we do randomization is because I want to be trustworthy as a researcher. And I want to make sure that there's no bias in my results. This is another slide that I show them in this prerequisite orientation. I tell them this is where you are. And then I walk them through a timeline of the whole process of what is going to happen in the clinical trial. And this is important to share the study details, to also share the time commitment so that people are aware of every detail that they need to know about what is actually going to happen during the clinical trial and whether the time commitment is something they want to even participate in or not. And then something that I do is I talk about retention. And this slide I show is why is it even important that you make sure that you complete all your A1Cs, because I do research on diabetes. Why is it important that you complete all your surveys, irrespective of whether we randomize you to a 6-week group or an 8-week group? And then I take time to explain the rationale. The reason is because we want to be trustworthy with our results. We want to make sure that we are actually getting a true picture of what program works better or not. And so I spend a lot of time explaining this as well. Now, this is where the motivational interviewing approach comes. And so I, as the PI, actually step out of the room. And this is what is recommended through that article, so I welcome you to read more, is I step out of the room and then our staff actually participate in a group discussion with this potential. At this time, there are still potential participants. And we have a group discussion about what are the pros and cons? Because remember, we are trying to diffuse any ambivalence they might have. What are the pros and cons about being in the program? We know that this is going to be hard to commit to, so let's talk about it. And then also talk about what is not, why should you participate in the program or not be on your own? And our clinical trial staff, they take notes, they put things on the whiteboard, and we have a conversation about it while I am not in the room. And so this is an example of a way where we've infused steps to be able to empower the community through our clinical trials, increase research and health literacy, and also be able to make sure that people actually understand every single detail of their clinical trials that they're participating in. So I'm going to shift gears a little bit and talk about initiating engagement. What happens at the very beginning? I like this quote by Dr. Smith, who is the dean of the Charles Drew College of Medicine, where she says, "It matters what we do. Compensation is good. Getting our data is important. but it might not be important as how participants feel at the end of the clinical trial. And what actually do we do to our participants as part of engagement in the trial? Also, things to think about is building on the strengths and enhancing the resources of that community by authenticity, by transparency, and actually investing. A friend of mine just told me about a university I will not name, which is like 2 miles from a very impoverished population. And that is not the way we want to see ourselves as institution. We don't want to be 5 miles from a community setting that doesn't have resources. And so it's important to think about how do we make financial investments? And so it's spending time to make sure that a lot of money is allocated to the community partners that we are working with as we think about our clinical trials. Something to also think about is acknowledging and addressing whatever might be an historical or contemporary race experience of racism that they might have experienced in the community. And it might not only apply to an historic marginalized community, but it might be a community that you're working with as well. Something that I will quickly mention also about building on strengths as well is a friend of mine told me, a colleague told me something that no community is a liability. Every community has its own strengths, and all we have to do is just build on it. And this is where collaborative partnership with them, knowing that they are experts in their own community, co-learning, co-designing, co-creating, whatever term you want to use in what the study details is going to be is important. I talked about how we balance research and action at the same time. And a really good way to do that is actually focusing on what is the local health issues of that community. Of course, thinking about long-term sustainability as well. Even if you know your project is not going to be sustainable at that point, we are always very clear at the very beginning that we can sustain this now, but hey, why don't you partner with us about thinking about ways we could sustain this in the future? And then, of course, having that personal stance and that interpersonal stance of cultural humility. Capacity building and sustainability also is important. And this is where coming together with the community organization, thinking about what is the need of that community that is going to be tangible to them when it comes to benefit, and actually working with those target populations, your stakeholders, and letting them take the lead. They have power. Why don't you share the power and allow them to take a lead on a couple of things? They could take a lead on implementation. They could take a lead on data collection. They can take a lead on even helping you to hire staff from the community. And that is one way to build and think about capacity building for these communities. Another thing that is also important to think about is including whatever is that innovation of that trial into what is normal for the community. And that is why pragmatic trials, implementation trials are sort of the way that even federal organizations and the NIH and a lot of federal systems are looking for now, because they want you to embed your process into something that is already existing and is already an infrastructure that's already been built. So I wanted to talk a little bit about focusing on that community of interest. It's important to think about how do we address the local long-standing barriers to why they don't want to participate in clinical trial. One of the things I've learned is that every community is different. We've done trials in Madison, we've done trials in Milwaukee, and there are certain politics around each community. And we have learned from working with community partners that what works in Madison might not necessarily work in Milwaukee or work in Racine. And this is why it's important to think about and talk to partners and not pretend to be unaware of what are the issues that we might face as a barrier to clinical trial participation. So I'll give you an example of something I encountered recently. We had a certain amount of money that we were going to provide as compensation. We had used the same money, we had budgeted it for all our trials, and we said, we are just going to use that. Well, we went to a different community and we talked to the partners and they're like, no, that amount of money is not enough compensation for this community. We needed to increase it. And so some of the staff was like, wait, that was what we did. And then we had to listen. And guess what? We had to go change the amount of compensation because we wanted to be responsive. And then I'll put a plug in. as a way to earn the trust of historic marginalized community for Just Research, which is a new program through the center that I'm part of, the Collaborative Center for Health Equity. This is for researchers, research staff, for you to learn skills to promote research equity and diversity in study participation as a way for you to continue to think about how can we enhance diversity in our clinical trial participants and their participation. So that's just a plug for that. Now, trust in clinical trials, that's a big word, getting trust from the community. It's important to think about working to be trustworthy and not asking the community to trust you when you have not acted in a trustworthy manner. And a trustworthy person basically keeps their promises. They say and act and do what they say they are going to do. And if they are not able to do it for any reason, they are transparent about it and saying, you know what, because of the goals, because of our funding, because of feasibility issues, we are not able to do it. And they let the partners know very early. And that trustworthiness on the part of the researcher becomes important before that community can then say they can trust you. Health literacy is actually an important way to build trust. And one of the things we say on the National Academies of Science and Engineering Roundtable on health literacy is, if I can't understand what you're saying, why should I trust you? And so this is where accessibility of information about clinical trial information becomes important, because if not, people will feel like you're withholding information about the clinical trial, or they are being sold something that is going to be profiting the hospital or profiting the doctor, or they feel like they're being lied to. And so health literacy is a very good way as a bridge to build trust. Now, during the clinical trial, there are a couple of things to think about. How do we reduce the burden that participants might face to participating in the clinical trial? So a couple of things we've done is providing transportation, making sure that we are providing childcare, and even things to think about is maybe if you're in a rural setting, providing mobile units to go to that location to screen people so that people don't have to travel to you. During the trial is all about increasing access to people, whether through computers or providing technology access as well, because we know that digital literacy as well is also a very key component of individuals participating in trials. I already talked about partnering with trusted community sites, making sure that we are providing support to those sites and not just leaving them on their own to, you go recruit this many number of people, but we haven't trained their staff, we haven't provided the funds, provided the resources for them to be able to do it. And also, as the trial progresses, there are ways you can maintain touch points in the community. It's not about we go in and collect our data, but how do you keep connected to the community? Health talks, doing presentations, volunteering, so that people feel like you are there and are connected to the community beyond the clinical trial data that you want to collect. Other ways to begin to think about building this partnership and building trust is, how do people feel by being part of your study? Are they treated fairly? Are they treated justly? Are they treated in a respectful manner? And this comes beyond, oh, we've provided them compensation, but what is all the things you can do that is not necessarily monetary compensation? Calling them, checking on them, providing holiday cards. We've done that a lot in our studies during the holidays. During COVID, for example, there was no study going on, but we called our participants and let them know, we wanted to check up on you and see how things are going. It is how people feel by being part of your trial. And then, like I already mentioned, authentic transparency. It is okay to say we don't know, and I've done that, rather than compromise trust. And so it's all about human touch beyond just getting in and collecting your data. So I wanted to share an example of working with community stakeholders. And phase one, as you see at the very beginning, is where we partnered with individuals in the community when we were trying to decide what exactly are the interventions we should be doing to address diabetes self-management. So at the very first one, we spent time talking to them to develop the first 3 weeks. And then in phase two, started developing the solutions, the intervention processes, the intervention manuals, the way we were even going to order the interventions. This was us taking time to actually do this as well. And bidirectional communication becomes important. And so what we did with our board is we created a sheet called, "How are you making a difference?" And we would show them at every meeting we had, you gave us information and gave us feedback on this. You told us to include this session. The impact is we've decided to include it. They even gave us feedback on our logo. Well, we don't like your logo. And so we worked with our team and said, this is the way we've revised our logo. And even things like, how do you communicate with your pharmacist? What should you include in your facilitator guide for the interventions? They give us feedback on all of those. And something that is interesting is you can see that there are different colors between the orange and the purple. The one at the very right, which is the orange, was the initial sheets and handouts we were providing to show how we were using their feedback. And they even told us, yeah, we don't like that color. And so we had to change it to purple, which they preferred. And so every detail matters when you are collecting feedback from partners. So when you're also thinking about promoting relationships, it's important to realize that it takes time. Establishing relationships takes time. And this is why we start very early. Something that we've done is we go to community advisory boards. We work with them even before we submit the grant. We start very early. We get that feedback early so that we can incorporate that feedback even into the grant. And also it's showing that commitment that you are coming to the community early before the clinical trial has even started. Also realizing that recruitment and enrollment actually takes time. And so it also becomes important to start early so that you can build that foundation of trust. Other ways to incorporate health literacy as well is to the materials that we are using. So informed consent form, trial summaries, and I'll talk a little bit about that too. Realizing that sometimes you might need to work with the IRB to change protocol. We use 5th to 7th grade. We go actually take all our materials and run them through a readability checker. And there are so many readability checkers you can use. We currently use the French Kincaid, and we run it through to make sure that they're all within 5th to 7th grade language so people can understand what it is about the protocol we are asking them to participate in. So thinking about plain language that they can communicate to their family member when they go home about, oh, I'm participating in this clinical trial. Making sure they're using clear formatting, white space, bullet points. A very good system is chunk and check, and using straightforward active messaging as well in a way that is culturally aware of the needs of the community. So I like this example from the Women's Subjects Office, actually from the University of Iowa, because what they did is they actually provided alternative lay language for medical terms that can be used in consent forms for researchers at the university. And I thought this was a really good example of even how an IRB has worked to say, hey, if you want to use a medical term, these are some things to consider for your consent forms. So this was a workshop that we did on the National Academy Roundtable in 2019 about how you can incorporate health literacy throughout the steps of your clinical trial process, starting from the flyers, starting from the website design, and also getting informed consent. Is it truly informed consent in that they actually understand the information, or is it a 60-page document that a lot of people don't understand? Data collection forms, making sure that it's short and precise if possible, making sure that we're using plain language summaries. So what happens is at the end of the clinical trial, we actually publish a plain language summary that we disseminate as well. And also making sure that our materials has gone through some type of user testing before we actually use it, and making sure that study staff are all trained on cultural awareness and cultural humility before they actually start engaging with participants. I already talked about the fact that what is the experience of the participants? How do they feel in terms of their engagement in the trial? So those follow-up phone calls, those postcards, making sure that they feel engaged and they understand that we actually appreciate their involvement in the study. So this is an example of a retention letter that we sent to them and to our participants. And what I've showed is we use personalized language, white space, We make sure that things are bulleted, and we encourage them. We still want you to participate, and we thank them for continuing to make that investment in their health. And so we tell them, even if you haven't attended all the sessions, we still want you to come and check your hemoglobin A1C or check your at those data collection events that we're doing. Now the study is over, and post-clinical trial, we want to continue to engage. This is where you continue to collect feedback and starting to work with some of those clinical trial participants to become trusted messengers. So one of the studies that we did, we actually talked to some people, and they said, oh, I found out about the clinical trial through somebody. And we're like, wait, how? And they said, oh, the person participated in your study in 2019. And it was important for us to know that it was an individual who was a former participant who was now helping us to educate their peers and had become trusted messengers by talking to other people about the clinical trials. So participatory dissemination is something that it becomes important in community engagement. And this is where you work together with the community to discuss what you did, what you found, what is next, and what is missing. In community-based research, we want to close the loop. We don't want to swoop in and swoop out. And so you can also write papers with your partners. You can write a version beyond the journal that is actually more public-facing. One of our trials we actually published in Capitol Hughes and published it in a newspaper or in a neighborhood newsletter. And this dissemination that engages the community becomes really important. This is an example of something we do for all the studies we do. We do what we call a dissemination dinner. And this is just an agenda to show you what this looks like. We bring people together, we provide a meal. I do a little bit of a welcome. And actually for 2 different chairs in my department, I have them come in and do a little bit of thank you for 5 minutes. And that shows some institutional commitment to the fact that we actually are excited and thanking them for participating in the trial. And then, of course, I present the findings as well. So this is just an example of what that looks like in a dissemination dinner. So I'm just going to run through a couple of pictures. This is an example of a dinner that I did in 2017, thanking people and providing certificates. It was important because we actually didn't think about that. They came up with it, like, why don't you give us a certificate to say, oh, you participated in this study? And so we provided that during this venue as well. This is an example of another one in Milwaukee that we did. One of the studies we did was during COVID year, 2020, as you can see. And we're like, well, should we still do it? Well, our partner said yes, so we did it virtually. There was, and what we did is we actually had people go drop off meals for them at their homes in front of their locations, because of course we were doing lockdown, so that we could still keep the spirit of this participatory dissemination as well. This is an example of what a forward-facing, public-facing dissemination. We did a newsletter, it was bifold, and we disseminated this as well. We showed the testimonials of those who participated, all the partners were on there. So this is the front page, and this is the end. Usually we showed what the results are, and we distributed it, of course, as well to community. And then, importantly, we talked about next steps. So this is another way of disseminating beyond just the journal. Other things we've done is we've published with our community partners. As you can see, there's a church in Milwaukee that we partnered with, and we said, hey, we want you to write a paper with us. And this is another way of showing that commitment to the community as well. So a couple of final important guidance to consider is working with community advisory boards. It's important, and you've probably heard this several times, to involve patients as you think about co-learning and sharing with them. They are the best people to give you insights into what the challenges are, what the burdens are, what are the barriers to people actually participating in early elements of your protocol. Also hiring community members to do certain parts of the clinical trial, maybe helping you with the data collection, helping you with recruitment. And then also thinking about maybe there's a type of RCT design that ensures that everyone that can participate, maybe a step-wage design. And these are some of the things to think about when you are partnering with a community advisory board. Now, I know it's knowing where to start seems very hard, right? And so one of the things I wanted to show is you don't have to do it alone. There is the Community Academic Partnership through ICTR, CICHI, the Collaborative Center for Health Equity. They're already ambassadors in the community. And this is a stepping stone to initiating that conversation with community partners if you don't know where to start. So come talk to the Community Academic Partnerships and CICHI as well. And so I'll end with a couple of considerations when you're thinking of trial enrollment, questions that we should all be asking ourselves. Do we understand how participants choose to participate in the trial? Have we considered diversity when we're thinking about study coordinators or the healthcare providers that are going to assist with the trial recruitment? Are we thinking about recruitment challenges, especially for difficulties with accessibility? We actually just faced this in a clinical trial we're doing right now where, that's why I said at the very beginning, we make mistakes. We chose a location for individuals to come and participate, but we found out at a little late that there was no ADA capabilities. And we had one of our participants who was in a wheelchair. Well, what can we do? We switched the whole thing. We had to let people know we are sorry, but this is the reason why we are changing the location, because we want to be inclusive of individuals who might have a disability. Think about all the recruitment events in places that are trusted. I've seen people do going to a cultural festival, going to a barbershop, going to beauty salon, going to a social commercial venue, going to a parade. And think about what other ways can we recruit beyond the clinical location. And then, of course, I've talked a lot about health literacy, using plain language, multiple languages for limited English proficiency individuals. And then, of course, thinking of interpreters. And this is the last thing, is something we haven't done personally, but also thinking about electronic informed consent for a way for people to read and sign it without actually having to travel, especially if you're not able to provide transportation. And so I'll end with a summary of the things I've talked about. It's important to listen, active listening, think about authenticity and meaningful way to be seen as trustworthy, making sure that our trial represents the priorities of the community, and the way to do that is starting early before the grant goes in, thinking about how to engage community members early in the design of the protocol, thinking about making sure they are well informed. And I showed an example of a prerequisite orientation we do, and then making sure there's investment back, and of course, resources for sustainability. So thank you so much for listening today. I would be happy to take questions, comments, and thank you again for allowing me to be here.
Thank you so much, Dr. Shiyanbola. This was fantastic. Sarah asked a really good question. I mean, and it's a kind of she gave some context, so I'm going to read it all. Researchers have significant control over how they frame studies budgets they author. There can be less flex when awarded studies land here and are already set from other academic health centers and partners. How do you recommend UW signal even stronger its commitment to research that upholds DEI values that you're amplifying?
Wow, that is a big question, Sarah. I wish I could answer for the whole of UW in how we can show our commitment to research. One of the things I'll say is it comes from the very top as well, in terms of the leaders, those that are championing clinical trials, those that are championing diversity in recruitment for and enhancing diversity of individuals to participate in clinical trials. And so one of the things I would say is, hopefully there are leaders, and I know there are leaders in this group. We need to be that voice to the UW. We need to be the ones helping to champion these things that we're hearing and taking it back to leadership so that it can trickle down from the top to the bottom. Because if leadership is saying this is what we need to do, then of course it goes down to other people, other members of the community, goes back to other members of the scientific community to then be able to say, this is what we should be doing. And these are the best practices and the best ways to do it.
There are a ton of thank yous, and I echo that. And Randy Kimple has asked, as a cancer doctor, many of my patients have cancers that are thankfully rare. How do you recommend we engage with community members when time to enroll a patient is short and the cases are rare?
Yeah, that is a really good question, which is the time to enroll is short. And one of the things I would say related to that is maybe engaging with individuals in that community, the cancer community, at the very beginning, to also maybe talk to them. Because even I, as a researcher, I'm not going to have all the questions. Who else can give you the best way to enroll a patient when there are rare cases other than the members of the community? So another thing to think about is maybe you start off with individuals who have maybe participated in the past and engage with them and say, you know what, I am a researcher and I really want to engage, but I don't have enough time. What do you recommend? And you'll be surprised, our community members, patients themselves will provide information that we as a researcher are not thinking about. I know that has happened to me several times where I mean, when I started my intervention, I was going to do something in a pharmacy and they were the ones that said, no, not going to happen. So engaging with actual patient advocates, talking to them through some of the questions that you might have might be the best way, because we as researchers don't always have all the answers.
So,
oh, and I see Sarah also said talking to, yes, Dr. Word and Lucretia.
Fantastic. So I'm going to ask a question just from me. If you are a new investigator or a study coordinator, how do you recommend making that initial approach to a community group or to a patient board?
Yeah, great question. So, like I already mentioned, what we do, the approach and initiating the engagement matters. So I would say at the very beginning, I would recommend getting training first. And I put down a couple of resources on ways that ICTR CCHI is providing resources. So getting some training so that you know what is the best and culturally aware and culturally appropriate way to engage with the community. So that's the very beginning, making sure that we are well trained. And other things I would say is leverage the partnerships that ICTR and CCHI already has. Leverage those partnerships, talk to them. There are ambassadors already in the community that are already available that you can talk to. And the other thing is just do a scan. Find a community academic partner and say, I want to talk to somebody. And then they are the ones that would then recommend, you know what? This is somebody that is an informant in the community. This is a trusted messenger in the community that you should talk to before you actually go in and start saying, oh, this is my study. And so that is the other thing I'll recommend is first the training at the very beginning, working with community academic partners, and then talking, doing a scan. I want to talk to informants in the community. I want to talk to who the trusted messengers are. You know, I heard somebody say in a presentation, go out in the streets. It's what somebody said, and just go out and talk to people. And hopefully you're able to leverage community expertise from actual community members.
Sounds good. Are there other questions? I see a hand raised. Adate, I'm not sure if I'm pronouncing your name correctly. Do you want to turn your camera on and ask your question?
Sure. Hi, my name is Aditi, and I am interested in learning more about incentivizing community members' perspectives. So what are incentives beyond perhaps maybe paying them to be participants or contributing to the larger research subject? Have you found some unique incentives that you hadn't considered when you started your programs?
Yeah, thank you so much for that question. So we have, and this is why I talked about compensation is good, but our participants feel is also important. So we do a lot of swag, I'm going to be honest, for our participants. We provide things like totes for them to be able to carry their books that they're going to be using for the study. We provide, because I do work with patients with diabetes, we also give them water bottles for them to be able to drink, make sure that we are talking about them drinking water. Yeah, well, we are going to provide you a water bottle for you to be able to drink water. And so these are some of the things. And the last thing that I would mention is even things like certificates of participation is something that we've also done. We actually learned that. I'm not going to take credit for it from our partners. They told us that just giving them a certificate for participating in this trial, you'll be surprised how people said, you know what, I put it on my fridge. I let people know that I did this, and they felt so happy and empowered that they participated in the study. So these are some other things that are not necessarily related to compensation, but making them feel like they are connected to the group and connected to the study as well.
Thank you. And I see some comments giving me more insight on that. Thank you so much.
Oh, yeah, I like that. Community incentive, arranging for purchase of books for a local or school library. Very good. Ask questions about health and healthcare, connecting them to experts, and featuring them on local media segments. Yes, that is a very good one. We've done some radio as well, where we actually bring in and we actually disseminate some of our information through radio. So that's a really good one. TV, newspaper articles. Yes, I talked about the ones we've done through Capitol Hills as well.
We have a question about, are underinsured or non-insured being asked to participate in cancer trials? How is that community being approached about cancer trials and making them aware of participation?
Oh, that's a big question. I don't know about, I'm not a cancer researcher, so hopefully the other people in the room will know. I know Dr. Ward and Lucretia are on here from the Cancer Disparities Initiative, so I don't know if they'll be open to answering these questions, because that is an important population. I agree, whether they are underinsured or non-insured, and if they are being approached about being part of a trial.
Right, maybe others on the call will be able, or on the meeting will be able to answer that question. Somebody noted that they pay to use a community church's space for research activities, so that's also a good way.
Yep. Those are some things we've
Catering
also
for
done
local
as well.
business. That's great.
Yes, we try to do that as well, using Black-owned. Because I work with African American communities, we try to use Black-owned caterers as well to provide meals at every session. So I want to make sure that we can. Oh, Dr.
I will chime in quickly there, being mindful of time. So for research at the Cancer Center, health insurance is not required. So when we advertise the clinical trials, they're broadly advertised, and then depending on whatever may be needed, we work on providing these resources internally or through community resources. So know that it is not a requirement. And we are using all of the strategies that you shared, Dr. Shiyanbola, to really begin to expand recruitment and increase enrollment of underrepresented minorities in our cancer clinical trials. Historically, we have not done as well, but we're moving in the right direction. Still a lot of room for improvement, but we are on course.
Thank you,
so much,
Dr.
Dr.
Ward. Oh, and I see other comments as well saying that, okay, Dr. Kimple said it doesn't look at health insurance page status as well.
Great discussion. Any other questions before we wrap up?
Participation in this talk as I spend thinking beyond subjects. Absolutely.
Again, Dr. Shiyanbola, thank you so much. This was such a helpful presentation. It was fantastic. We so appreciate it.
Oh, you're welcome. It was good to see everybody. Thank you for inviting me again.
Outstanding presentation, Dr. Shiyanbola. I was so impressed. I signed you. I'm going to be reaching out for another presentation with our postdoctoral fellows, because this was just amazing. So thank you for all that you do and for helping us to continue to learn and grow.
Thank you so much, Dr. Ward. I appreciate you. You know, I respect you a lot, so I appreciate that comment coming from you.
You are welcome.
Thank you, everyone, for joining. Stay tuned. If you're on the listserv, I will be sending out information about our next seminar coming up in mid-May. If you'd like to join our listserv, please contact me directly, and I'm happy to add you. Thank you, everybody, and have a wonderful rest of your day.